Welcome to a CCIM demonstration on sharing assessments in IAR to support client care. Using a clinical scenario for a mock client, Mr. Douglas Barrell, we will demonstrate how the common assessment information available in IAR can be used to support client care. The scenario is taken from the perspective of two clinicians, a mental health case manager and an addictions counselor. They demonstrate how IAR can be used to view timely assessment information to better understand their clients' needs and enable collaborative care planning. So let's get started with the scenario. My name is Sally, and I'm a mental health case manager. Doug is referred to my community mental health organization in May 2016. As part of the assessment process, I will review information about Doug that was collected by other healthcare providers. IAR allows me to view assessments that will inform my work with Doug. I check to see if Doug has any assessments on IAR by entering his name and date of birth. On the timeline, I see that Doug has one assessment, the RIMH, used in inpatient mental health services. It was completed on May 2, 2016. So I know that Doug was recently hospitalized for mental health reasons. I open it up and review it to gain an understanding of Doug's condition to inform his service plan for case management. I jump to section CC to find out why he was admitted to hospital. Under reasons for admission, I learn that Doug was a threat or danger to himself. To learn more about this, I go to the summary, as this focuses on risk factors to be aware of for Doug. Section D, harm to self or others, shows that Doug had a past self-injury attempt more than a year ago. Precipitating this recent hospitalization, Doug had intent to injure himself. His family and friends expressed concerns, and he had formulated a plan to end his life. With this information, I know that part of my work with Doug is to develop a crisis plan that documents the actions Doug would take to get help if he experiences thoughts of suicide while in the community. I go back to the detailed assessment and take a look at section G, self-care. Doug was assessed as requiring supervision with personal hygiene, extensive assistance with meal preparation, and supervision with managing finances. As a case manager, I can help Doug build skills in these areas. Now I have a better understanding of Doug and the support he requires. I then complete the OCAN with Doug and upload it to IAR. I work with Doug in the case management program, and I complete a 6-month OCAN reassessment with him in December 2016. During this assessment, Doug discloses that he has been using fentanyl, that he's been buying on the street. A referral was made to an addictions counseling service.
My name is Mohammed, and I'm an addictions worker. I'll be providing individual counseling to Doug. I use IAR because it provides me quick access to information collected by other healthcare providers working with Doug. I look him up using his health card number. I see that Doug had 2 OCANs completed. I immediately know that he has been receiving community mental health services. I take a look at the list of assessments I want to view and review the most recent OCAN, which has been completed in December 2016. I go to the detailed view. I want to find out what services Doug has accessed, so I go to the Mental Health Functional Center Use section. I see that Doug has been involved in a few types of community mental health services. Doug has been receiving case management services since the 14th of June, 2016, and I see the contact information for his case manager, Sally. I plan to give Sally a call. I take a look at the section on access to a family doctor. I learn that Doug has a family doctor, but he hasn't been seen for over a year. Doug needs to have more regular contact with primary care, and I will discuss this with Sally. The intake worker at my agency indicated that Doug has symptoms of depression, including thoughts of suicide. So I focus on viewing the following areas to understand the issues: psychological distress and safety to self. I review the information in the psychological distress domain. For question 1, both Doug and his case manager Sally rated psychological distress as an unmet need, indicating that this is a serious problem for Doug. For question 2, Doug was getting no support from family and friends. For question 3A, Doug was receiving some support from services at a low level of help. For question 3B, it shows that Doug requires help from services at a moderate level, so it was identified that Doug needed a higher level of support than he was getting. Comments explained that Doug was experiencing symptoms of depression. He was feeling more down, difficult to get out of bed, crying, and lack of motivation. As an action, Sally agreed to accompany Doug to his psychiatrist appointment. Under the safety to self domain, both Doug and his case manager rated this issue as an unmet need. Similar to the psychological distress domain, the responses to question 3 indicate that Doug required a higher level of support than he was getting. Doug reported that he recently had suicidal thoughts, but he did not have a plan to harm himself. He agreed to tell his psychiatrist about this. Sally and Doug reviewed his crisis plan to agree on actions to take if thoughts of self-harm escalate. I review the information in the drugs domain to get an understanding of Doug's situation as I begin my work with Doug. Both Doug and Sally rated drugs as an unmet need, indicating that it's a serious problem. He has not received support from friends, family, or services. Doug requires a high level of support to address this issue. He disclosed that he has a problem with the use of the opioid fentanyl. He explained that Percocet was initially prescribed by his doctor because he was experiencing a lot of pain as a result of an injury to his knee last year. He now buys fentanyl on the street. He indicated that his use has increased and it's now affecting his day-to-day life. Doug is not able to pay his bills, and he's worried that he's at risk for losing his housing. The action that Sally and Doug agreed on was referral to my agency for addictions counseling and to attend Narcotics Anonymous. I jump to the summary of action section. This allows me to see the priority domains and the actions that Doug and Sally were focused on. Safety to self, drugs, and psychological distress were identified as priority areas of unmet need with actions to address his needs. Money was identified as an unmet need, with the action being to support Doug with budgeting his money and improving his financial literacy. Company and intimate relationships were also identified as areas requiring support. This information has been very helpful as I plan the focus of my work with Doug. He is struggling with both mental health and addictions issues. His suicidal ideation and use of fentanyl increases his risk of suicide, and this needs to be closely monitored. My practice includes focusing on the areas of life that drug use has negatively affected. Knowing that Doug's money and social network are key areas of need informs my approach to the work with Doug. I will now contact Sally to coordinate the support we're providing Doug.
Mohammed called me, and it was helpful to share information and coordinate our service to best support Doug. I went with Doug to his family doctor, and Doug complained of feeling tired, weak, and having trouble breathing. His doctor sent Doug for tests. Doug was having difficulty functioning in daily activities, so we decided to have him assessed by home and community care. I then go into IAR and complete a search for Doug to review any recent assessment information. I see that Doug had a RI-HC done, the common assessment completed by home and community care. I want to understand his health condition, so I go to Section J, Disease Diagnosis. I learn that Doug has been diagnosed with congestive heart failure, with a code of 2 indicating that this condition is being monitored or treated by a home care professional. I go to Section H, Physical Functioning, and I look at the second column labeled Difficulty. I look for a code of 2 to identify the areas he is experiencing great difficulty in. These instrumental activities of daily living include meal preparation, ordinary housework, managing finance, shopping, and transportation. On the other hand, he is independent in most of the activities of daily living, such as dressing and bathing. This helps me to quickly understand his strengths and deficits. As part of my job, I will focus on helping Doug to build skills in some of these areas and link to other supports that can assist him, such as Meals on Wheels. I want to know what kind of support was put in place through home and community care, so I go into Section P, Service Utilization. Under Formal Care, it indicates that Doug is receiving support from home health aides, twice a week for 4 hours to assist him. Under Special Treatments, Therapies, Programs, it indicates that Doug is in drug treatment that is scheduled with partial adherence. This must be the counseling he's receiving from Mohammed and the Narcotics Anonymous meetings. I will share with Doug that I have reviewed this assessment and discuss the impact that his physical health condition may be having on his mental health and addictions issues. I will ask his permission to join him, Mohammed, and the home and community care worker in a teleconference so we can work collaboratively to support Doug. Thank you for watching this video. The scenario has provided you with a practical example of how common assessment information available in IAR can be used to support client care. If you have any questions or comments, contact us by email or by phone through the contact details listed here.